Hi, my name is Marcus Butler. I'm a medical oncologist uh, here at Princess Margaret in Toronto, Ontario. I'm a member of the tumor immunotherapy program here and a site lead for the
Hi,
melanoma.
my name is Marcus Butler. I'm a medical oncologist uh, here at Princess Margaret in Toronto, Ontario.
Thanks. Um, and I'm joined here with fellow panelists, Dr. Anthony Joshua, who is Director of Oncology at the Kinghorn Cancer Center and Garvan Institute of Medical Oncology. Dr. John Crown is Professor and Consultative Medical Oncologist and Chair of Translational Cancer Research at St. Vincent's University Hospital, Dublin. And Dr. Richard Coverhall of Columbia University is Director of Experimental Therapeutics and Melanoma Service, co-leader of Precision Oncology and System Biology program at Columbia Herbert Irving Comprehensive Cancer Center. Welcome and thank you for everyone joining the Clinical Trials International Overview. I'd like to first start with each of our panelists describing their multidisciplinary team that takes care of patients with uveal melanoma and how that interaction works with clinical trials. I'll start with our own group. We have a group of radiation oncologists and ocular oncologists housed at Princess Margaret, as well as medical oncologists that take care of our patients. We have physician assistants and research nurses that are part of the group and conduct clinical trials as well as administer therapy. While we don't have any trials in liver-directed therapy, we work closely with the interventional radiologist to offer uh, 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 TACE or Y90 radioembolization procedures, as well as clinical trials. I'll move first to Dr. Joshua, if you could describe your team. There may be a delay on Dr. Joshua's side, so I'll.
Uh,
Oh, there you are. Go ahead.
we have an Australian channel. Um, uh,
I think we're having some technical difficulty with with Australia, so let's move to Ireland. Dr. John Crown. Dr. Crown, unfortunately, we're having trouble hearing you. I don't know.
I'm sorry, and it was my fault. You can hear me now. I'm
Okay,
very
yeah,
sorry.
start over
Sorry.
again. Thanks.
I turned off because I was getting a lot of feedback before. Sorry about that. We have. I'll be brief. I'm sorry.
Dr. Crown, unfortunately, we're having trouble hearing you. I don't know.
I'm sorry, and it was my fault. You can hear me now. I'm
Okay,
very
yeah,
sorry.
start over again. Thanks.
I turned off because I was getting a lot of feedback before. Sorry about that. We have. I'll be brief. I'm sorry.
Dr. Crown, unfortunately, we're having trouble hearing you. I don't know.
I'm sorry, and it was my fault. You can hear me now. I've turned down the volume so that I hope you can hear me, but I'm hearing myself coming back several times. Basically, in Ireland, we have possibly the highest incidence of uveal melanoma in the world. We have been estimated certainly to be one of the top few. The care is highly centralized. One onco-ophthalmologist, Professor Horgan, looks after all of the primary ophthalmological care. Those patients who have plaque radiotherapy are all treated in one hospital, and all of the follow-up and the systemic treatment is done under my care in St. Vincent's University Hospital. We would have approximately 5 to 7 new cases of metastatic uveal melanoma per year. We do not have chemosaturation therapy in Ireland. We've had excellent cooperation from our friends and colleagues in Southampton in England for patients who are referred there. Our approach tends to be primarily immunotherapy for those that are not suited for liver-directed therapy. Our hospital is also the National Centre for Liver Surgery, so we've had an active program in doing liver surgery on these patients.
Great, thanks very much.
To be primarily immunotherapy for those that are not suited for liver-directed therapy. Our hospital is also the National Centre for Liver Surgery, so we've had an active program in doing liver surgery on these patients.
Great, thanks very much.
To be primarily immunotherapy for those that are not suited for liver-directed therapy. Our hospital is also the National Centre for Liver Surgery, so we've had
all right, and Dr. Carvajal?
Yeah, so what I'm going to do, I'm going to turn my volume down and just keep on speaking. So at Columbia, we do have a weekly meeting where we review all of our new and follow-up uveal melanoma cases. So much like the rest of the group, we have Dr. Mara there as our uveal melanoma oncology specialist, we'll review kind of the either surgical or plaque brachytherapy plans. We also have both diagnostic radiology and interventional radiology as part of that as well. So we'll review all of the, let's see, I'll just keep on speaking. And so we do review all of the liver imaging as well as the systemic cross-sectional imaging. And then we do discuss whether we should pursue primarily a regional therapy versus systemic therapy. In terms of the regional therapies, we do offer bland embolization, immunoembolization, radioembolization, or TACE or chemoembolization. And then we do have a whole portfolio of systemic therapy trials as well. And so again, the decision-making for this disease, I do think is pretty complex. And so I think that multidisciplinary interaction between ocular oncology, medical oncology, interventional radiology, and others is really critical.
Great. Dr. Joshua, in terms of clinical trials versus standard of care, which do you prefer?
Well, in my opinion, I think we're still looking to improve the care of, in particular, metastatic ocular melanoma. Primary is a different thing. And I think there are some well-established treatments for primary ocular melanoma. But in metastatic disease, my default is a clinical trial. There's an exciting amount of research going on. And of course, clinical trials are not for everyone. And I certainly go through with my patients the benefits and disadvantages of participating in a clinical trial. And in Australia, it's particularly difficult because we don't have access to combination ipilimumab nivolumab for uveal melanoma on our Medicare system. We're only restricted to one of those drugs. So there's even greater impetus to participate in a clinical trial here because we don't have access to the combination on the healthcare system.
And that is setting uveal melanoma apart from cutaneous. Is that correct in Australia?
Yes, that's correct. For reasons which are a little bit unclear, the government specifically excluded uveal melanoma. There's a much emphasis on participating in clinical trials for metastatic uveal melanoma. Unfortunately, at the moment, at least, there are a number which are open.
And Dr. Crown, do you have access to combination immunotherapy for your uveal patients?
Much emphasis on participating in clinical trials for metastatic uveal melanoma. Unfortunately, at the moment, at least, there are a number which are open.
And Dr. Crown, do you have access to combination immunotherapy
Yes.
for your uveal patients?
We have now, and it's interesting when you look at the cohort of patients we've had that have had very long-term survival. They all had immunotherapy, and 3 of them have had ipilimumab and a PD-1 drug, either in combination or in sequence. A lot of it reflected health economics, but now we have full access to both drugs. And more importantly, for the first time in the last month, we're able to give what I believe is the more rational dosing schedule with the lower dose of IPI and the higher dose of Nivo. Previously, this inhibited us a little bit from giving combination to some patients. We had concerns about toxicity.
How about you, Dr. Carvajal? Are you giving combination immunotherapy to most of your patients?
But in terms of patients who are not trial candidates, I have been doing combination ipilimumab and nivolumab as the first-line systemic therapy standard of care. It's been my practice to do full-dose IPI, so the IPI-3 Nivo 1, despite the higher rate of significant side effects. I think, Professor Crown, it's the toxicities are certainly a significant issue. It's just not clear to me whether PD-1 is the driver in terms of potential benefit in this case, or CTLA-4. And so, right now, based upon the data that's come out of Spain, MD Anderson, and some of the retrospective series, all of that right now is with full dose IPI. And so I've been erring on the side of doing that. And we have had some clinical benefit, but certainly the toxicity is a major issue. And so I have been prioritizing patients for clinical trials, if at all possible.
I thought one of the interesting discussion points on a previous meeting a few months ago was that in some jurisdictions in the UK, when patients are not candidates for combination immunotherapy, they prefer giving anti-CTLA-4 as opposed to anti-PD-1 for patients. Has anyone else been doing that for first line?
That's a great question. I've been for single agent therapy. I've been starting with single agent PD-1, but you're right. I don't know. It may be CTLA-4 is better in this setting.
Sorry, I put myself on mute. Sorry about that. I was wondering, what is the general percentage of patients that go on to clinical trials, either phase 1 or phase 2 trials? So let's start with Dr. Carvajal.
Yeah, so I think we're fortunate to have a pretty broad clinical trial portfolio. So, I'd say at least 2/3 of our patients will end up going on a trial, either frontline or as a later line therapy. Right now our trial portfolio is heavily weighted towards systemic options, looking at either novel immunotherapies, epigenetic therapies, or targeted therapies. I think we're very interested in kind of building up a regional trial portfolio as well. Local control obviously is so critical in this disease.
Yeah, that's absolutely true. Dr. Joshua, in terms of clinical trials and
Yeah, so I think that I would say probably about, in our case, probably over a third of patients would go on clinical trials. Clinical trials are not necessarily centralized at my hospital. We're in close contact with the other hospitals that have some uveal portfolios. And so we do send patients around the city and sometimes around the country to get on clinical trials. So that for systemic therapies, and ours is also very heavily weighted to systemic therapy as opposed to infusional liver-directed trials. Generally the patients are younger and very well informed. And so I would say that in our centre, it's probably at least a third of patients that get on a clinical trial.
And Dr. Crown, there's a question from the chat in terms of what gives you the most hope for patients with uveal melanoma. Would you like to speak to that? Chat in terms of what gives you the most hope for patients with uveal melanoma. Would you like to speak to that?
I possibly have a prejudice, but I like to think it is going to be some version of immunotherapy. I think if we look at the transformative effect immunotherapies and had in other cancers, and the recent MD Anderson data, some of our own long-term follow-up data, there clearly are a percentage of patients who do rather well with immunotherapy. And what we want to do right now with our exceptional responders research is to try and find out what are the characteristics of the patients who get these unusually good results, and can we learn from them what makes them different from the ones who do not. And what we want to do right now with our exceptional responders research is to try and find out what the characteristics of the patients.
Dr. Joshua, what gives you the most hope?
Results, and can we learn from them what makes them different from the ones who do not. What we want to do right now with our exceptional responders research is to try and find out what the characteristics of the patients.
Dr. Joshua, what gives you the most hope? So I'll move on to Dr. Carvajal. Can you speak to what gives you hope for the field of uveal melanoma and what you think is coming around the corner for patients?
I'm extremely hopeful for where we are in this disease. When I look at the classes of drugs that are being developed, let me shut my volume down. It includes kind of the novel immunotherapy or cell therapy approaches. Also still includes the targeted therapy approaches and the epigenetic strategies. Across the different strategies, I've been seeing really promising results across the board. I think many of us are biased towards the side of immunotherapy, and I think the data that's been presented for the Immunocore IMC GP100 drug certainly supports that enthusiasm. And obviously we'll have data from the randomized trial hopefully coming out next year. But the idea of just bringing in the immune cells into proximity to the tumor cell, the fact that that's enough to engender what may be a survival advantage, I think is really, really promising. But even if we look at some of the other strategies that are being approached, things like PKC inhibition, for instance. If we look at the the IDEA drug that's now being studied in combination with MEK inhibition and other combinations in the future, when that drug was being studied by Novartis, and when you look at the cohort of patients who were treated at the BID schedule, the schedule that's going forward, a quarter of the patients were on drug a year or longer, doing well. And so even though, if we look at the median duration of response or the median outcomes, maybe that's not as good as we want it to, there's still a significant proportion of patients who get some benefit. And so I think to Professor Crown's point, the key is identifying which patients are going to benefit from PKC-based therapy or what patients are going to be benefit from checkpoint inhibition. And that's really the key because, it's clear that it's not going to be a one-size-fits-all for this patient population.
And Dr. Joshua, what do you think is the the ideal patient for a clinical trial?
Well, I guess there's two aspects. One is they have to be eligible, motivated, and um, and also I think that we have to be comfortable putting them on a clinical trial in terms of their disease burden and the growth of their disease. But the most important thing is the patient understands what's going on. They understand the nature of the treatment they're embarking upon. They're willing to go through the journey of the clinical trial with both their family as well as with their treating melanoma oncologist. And obviously, some of these things can be incredibly burdensome on both on the patient as well as their family. TIL therapy is not a walk in the park, and especially in the COVID era, being isolated and not being able to have your loved ones visit is an incredible imposition on the patient and their family. So those sorts of things do weigh on my mind when I'm discussing clinical trials with patients in terms of the imposition for travel and isolation. Some of them may actually involve. So it's a really complicated decision as to what's the best candidate. I think that ultimately it comes down to the benefit risk ratio, and that risk does include both emotional risk as well as side effects.
Thanks very much. And Dr. Crown, do you want to speak to to your patients in Ireland and their access to clinical trials?
Benefit risk ratio, and that risk does include both emotional risk as well as
I'm still hearing the previous question echoing. I'm sorry, I couldn't hear that, Marcus.
Very much. And Dr. Crown, do you want to speak to your patients in Ireland and their access to clinical trials?
Benefit risk ratio, and that risk does include both emotional risk as well.
I wish it had been better. We have not had good access to trials.
I couldn't hear that, Marcus.
We have not had as good access as I would like, and certainly as good as we've had in other diseases. And it may.
I wish it had been better. We have not had good access to trials. I couldn't hear that, Marcus.
We have not had as good access as I would like, and certainly as good as we've had in other diseases. And it may. And I would hope possibly as a result of our discussions today, if any of my colleagues certainly would like to collaborate, if any of you have trials that, where you think our accrual of perhaps 4, 6, 8 patients per year in metastatic trials would be useful, we would be very keen. We would be very keen indeed to try and come on board with them.
Yeah, I think that's absolutely true for this disease, which is rare. International collaboration is absolutely key to access. Not all of us can live in Manhattan with easy access to multiple cancer institutions. In terms of liver-directed therapy, that often is not been subject to rigorous randomized clinical trials. Dr. Crown showed a study that was actually negative, but it still is used in the management of patients, and logically it makes sense to control patient disease that results in their death. So if we can have responses in the liver, it seems as though patients should do better. Richard, do you think that there's any path forward to really nailing down the appropriate timing of liver-directed therapy in the course of patients, especially as we have treatments like immunotherapy? In my own practice, I'm never really sure which is better for my patient when they have small disease, liver-directed therapy, or get them on immunotherapy when they may respond well. What is your practice?
I don't know. This is such a critical question. In fact, over the past several months, I've been trying to kind of pitch the concept of, this is a question, I think, or one of the few questions that that I think is potentially answerable by a big clinical trial, right? Because in my mind right now, that's a completely unanswered question, whether systemic therapy is any better or any worse than regional therapy. And I think, we're at a place where in terms of systemic therapy, we could say, checkpoint blockade, either single agent or combination is what I think many of us would consider a reasonable standard of care. And for the regional therapies, I'm very comfortable offering chemo embo, radioembo, or immunoembolization as well for patients with liver-only disease. In terms of trials, you could imagine, a definitive trial of checkpoint blockade versus regional therapy. That's a trial that would have to be done, either nationally or probably globally, to be honest. And we've run the biostats for something like that. That's it's a 300, 400 patient trial, which would have to go through some sort of cooperative group, because I can't imagine that industry would be interested in supporting something like that. So I guess you asked regarding my practice. I think this is something that we just kind of discuss on a case-by-case basis. This is something that I do offer to the patients. And it's kind of like in the BRAF melanoma population. Do you do targeted or do you immuno frontline? For the uveals, it's should we do systemic? Should we do regional? Or, to be honest, I've been kind of combining them in some cases as standard of care as well.
Dr. Crown, do you have a preferred approach in terms of liver-directed therapy or immunotherapy? Yep, so your volume is down.
In the first instance, if patients have very oligometastatic disease, we refer them for surgery. In terms of liver-directed therapy, if we want to give them chemosat, it involves leaving the country. It involves going to England, and we have done that on occasion. It probably has had the effect of subtly biasing us in favor of immunotherapy, which we can give, and which I guess I'm not convinced in terms of long-term data is clearly that inferior for many patients. We are trying to upregulate our access to different forms of liver-directed therapy in-house in the country, and I think we probably will soon. But again, I would defer to my colleagues. It's not clear to me that there is clear data that when you see the immunotherapy data now that it is greatly superior to go with chemosat.
Mm-hmm. And Dr. Joshua, do you have any thoughts on liver-directed therapy versus immunotherapy?
Look, I think they're both valid options. You just have to take the patient on the journey of what they both involve. From the Puma data that we analysed, the patients that received liver-directed therapies, it looked like they did a little bit better than immunotherapy. But mind you, most of the Puma data was before the era of immunotherapy. And also it did appear the patients that got liver-directed therapy did better, were better patients and had lower volumes of disease. So it wasn't clear. I do see the liver-directed therapy as being more of a sort of a procrastination tactic, because inevitably there may be some extra hepatic disease that may mandate the use of systemic therapy. But I've had some very, very prolonged responses to liver-directed therapies. We use intrahepatic photomustine and occasionally Surspheres, nothing fancy like Dr. Carvajal. But so I have seen some very prolonged responses, especially in the elderly, where they don't particularly want to go on immunotherapy, and certainly combination therapy I don't particularly want to give them. So I have seen some very pleasing responses that have allowed us to bridge, and the younger patients allowed us to bridge them onto clinical trials as well. And since it's not a systemic therapy, sometimes it's sort of easier to get the patient onto a clinical trial.
Yeah, we now have in Ontario access to liver-directed therapy locally. We no longer have to send patients to Jefferson in Philadelphia. Well, this brings us up to the half hour. Thank you very much for the panelists and soldiering through the technical difficulties. I think we definitely have a sense that there's an international interest in clinical trials and getting better treatments for our patients, and also enthusiasm for people all over the world to work together to fight this terrible disease. So, however, there's much hope for the future, and I think we'll really be able to crack this, hopefully, in our lifetime. Well, thank you very much, and have a good rest of the weekend.